what specifically in her history puts her at risk for hypervolemia? Her heart failure. So what is going on with heart failure? There's a decrease in something. There can be decrease in cardiac output, right? So that decrease in cardiac output, that is related to her congestive heart failure. So that's going to put her at risk for fluid volume overload or fluid volume excess. So how do these dill pickles and sauerkraut impact her fluid volume? Sodium and water retention. So that's what I heard. Very good. So that's going to help her, or help her, not help her. That is going to actually hurt her with sodium retention, which is going to make her have excess fluid on her wherever. So where would we see that excess fluid if we were to assess the patient? Her feet, her face. Where in her face? Where might you see it? Eyes, maybe. Periorbital edema, right? Where else? Her back, her sacral area, her feet. Some patients who have CHF, some of them have it in their abdomen. Where's a place that you may not see fluid overload but could be present?
Your lungs.
Your lungs. Very good. Very good. Very good. All right, very good. So why would your patient be on a fluid restriction while they're in the hospital? Okay, so to prevent fluid overload. So let me ask you a question. If she is on fluid restriction, what would be a danger of putting a patient on fluid restriction? What electrolyte imbalance could happen? When you think of water, what do you think about?
Sodium.
Salt. So what electrolyte balance are you going to start thinking about? What's hyper? Hypernatremia, right? So if I'm restricting your water, who normally has a decreased thirst mechanism? Older adults, younger children, people who cannot get to water have issues with sodium balance, specifically hypernatremia. So if we're going to restrict her fluids, we have to keep an eye on her sodium level as well, because she's also 92 years old. So that's going to put her at risk for things that may not be as obvious in a younger person. So you have to consider the age of your client. What is a normal gerontological change for that client? How is this going to affect a client of that age? Okay? So answer the question, but think about the answer deeper. So what nursing interventions are we going to do for this patient on fluid restriction?
Monitor and test.
So we'll monitor her electrolytes. Go ahead, V.
Can you explain why it's hyper and not hypo?
So hypernatremia, so I'm going back to path, we're going to actually talk about it in a little bit. So what is the driving force for water intake? Thirst, right? So if I am not getting enough water in my system, my sodium is going to shift. It's going to shift from inside the cell to outside the cell. So we're going to talk about that in a little bit. But one of the most common reasons for a patient to have hypernatremia is because of a decrease in their thirst mechanism. There's some other things like diet, that kind of thing, but hypernatremia is going to be linked to a decreased thirst mechanism. Do y'all remember that from last semester? Okay. I need y'all to pull all those fundamentals, electrolytes and fluids things up with you guys as we continue. And y'all don't get discouraged if you don't get everything right as we're doing it. This is not a, you should know this moment. This is a, let's learn it together so that way when you are ready to take the exam, you know it. So don't sit here and get discouraged either, because that's not going to be helpful. So eyes and nose, daily weights. What else are we going to monitor for this patient? What labs are we going to look at? So we can look at vital signs, B1 and creatinine. Very good. Anything else for her?
Would you monitor her heart's response to the fluid restrictions?
You can. So I would be more concerned with fluid overload, but you still want to monitor for both. It wouldn't hurt to monitor for both. Okay.
Can monitor for breath sounds too, because of the crackle.
If she goes into CHF exacerbation, yes. So because she has heart failure, you're always going to do a cardiac assessment, and part of that is listening to the lungs and the heart.
Would you also do like dietary restrictions?
What kind of dietary restrictions, Imani? Sodium restriction, good. So most of your patients who are CHF patients will be both on a sodium kind of specific diet and fluid restriction. So that fluid restriction is not just, you can have 900 mLs of fluid in the morning and then you can have 500 in the afternoon or something like that. It's typically each meal, they have a set number of fluids that they can have. So typically your patients who have heart failure, they may be on a 1 liter to 1.5 liter fluid restriction. What were you gonna say, Molly?
I was gonna ask, I don't know if it would fall under like a nursing intervention, but also like the amount of people that could be coming to see her, would you be telling them like make sure even if she asks for it?
Yes.
Like, y'all aren't gonna get the.
Yeah, I mean, I'm 92 years old, I want some ice cream. Why don't you just give me my ice cream? I've been around for 92 years. You're gonna deprive me of my ice cream? I'm a real patient. What would you tell me? You are? You're mean. You don't care? Work on your therapeutic community. I'm just kidding. Right, but that's the thing. You need to educate family as well. So that was very good. That is a nursing intervention, by the way. All right. So how is body fluid composed in the cell, outside the cell, all those good things? So this again is going back to our patho. When we start talking about things like fluids and electrolytes, we really are looking at a lot of the things in the extracellular fluid space. What lab are we going to use to assess our patient's electrolytes? What lab would you expect to be drawn? I heard something with a P. Did anybody say a BMP? Do y'all remember what a BMP is?
Blood nitrogen?
Basic metabolic panel.
Oh, man, that was way off.
Right? So a BMP is going to assess your patient's electrolytes. So that is what you're going to use. So we already kind of talked about where the fluids are, or what fluids are located in the different body cell compartments. Most of your fluid that we're going to talk about is going to be in this intravascular or plasma section here. So when we start talking about fluid and electrolyte shifts, that kind of thing, we're going to be talking about fluid located in this space specifically. Most of your potassium is going to live right here. So even though most of your potassium is inside the cell, the 2% that's outside is that vital that it's just that important that we talk about it. Go ahead.
You said blood metabolic what now?
Basic metabolic panel.
Basic metabolic.
So that's a BMP. Okay. So speaking of electrolytes, we're not going to go back to chemistry and talk about cations and ions, all that good stuff. But you know that electrolytes are positively and negatively charged, and that's how they work to maintain balance. So potassium and sodium are two of the most abundant electrolytes either inside the cell or outside the cell. So that's why they are so important for us to monitor, and they affect a lot of things. So potassium, magnesium, and phosphorus are kind of like sisters. They typically all hang out together. They have a lot of the same kind of similar clinical manifestations. So sometimes it gets a little tricky to kind of say, is this an electrolyte for potassium or magnesium imbalance? But you have to look at your whole patient. But potassium, magnesium, and phosphorus like to hang out together. Sodium just is everything, right? Because salt and water are kind of like this, they're married. So anytime we think about a sodium imbalance, I want you to think about what is going on with water in the body as well. And when we think about sodium imbalances, what does that affect in the body? What would you assess for a patient with a sodium imbalance? You did this, good, level of consciousness, right. So you want to make sure you're doing neuro assessments for patients with sodium imbalances. It doesn't matter if they're having hyper or hyponatremia, you need to monitor their neural status. So we'll talk about that more in a little bit also. So we're not going to spend too much time on transport processes. Basically, this is saying that fluid is shifted in the body. It moves between compartments because that's the way the body is designed. It can move through osmosis, which is just passive, sometimes we feel like we just sit in class and we're just going through osmosis. We're like, right? That's how we feel sometimes. So that is just no energy, it's just a normal process that happens. Water really is the main thing that is moving through that membrane. Diffusion goes from higher concentration to lower concentration, and you should remember your CO2 and O2 from your respiratory lecture. This is where that alveoli junction, that area where that diffusion happens, where that exchange happens between the oxygen and carbon dioxide. So that's your diffusion process. And then filtration requires some force. So this is hydrostatic pressure. And so what system did we talk about that deals a lot with filtration? The GFR, right, so the kidneys. So when you're thinking about filtration, think about things moving, things not being able to move. There has to be some force or pressure applied for that. So speaking of pressure, we do have oncotic and hydrostatic pressure. And y'all, these are just things to kind of refresh what we've already gone over before. But oncotic pressure is going to be more of that pulling pressure. So things like albumin, which is a really important protein. Albumin is a big protein that has oncotic pull or oncotic pressure. Does somebody have their hand up over there? No? Okay. So when we think about oncotic pressure, we're thinking about pulling things. We're thinking about expanding the vascular space. Hydrostatic pressure is going to be pushing. So think about like blood against a blood vessel. That's going to be like your hydrostatic pressure. So even though we're talking about fluid and electrolytes, remember particles move, blood has to move, things can go from different compartments, intravascular to extracellular, or extracellular to intracellular, excuse me. So things have to move, and they move by these ways, by pressure and by energy or no energy. Okay, so tonicity. How do you know what type of fluid you're going to give your patient? Go ahead, Stephanie.
Patients with problems with
Say that again. Patients with problems with what?
with liver problems,
Mhm. So they can have albumin, but you have to be careful because it's a protein and we're thinking about the liver. We're going to talk about some of those patients and like LR, that kind of thing. All right, so when we're talking about a hyper iso and a hypotonic solution, let me go back. What kind of things do y'all remember about those?
When it is from the cell.
So some things shrink the cell, what else? Some things expand the cell, okay, what else? And some things just kind of stay the same, right? So what is tonicity? What is that? What does that word mean? Right, so tonicity is how does the solution move in the blood, right? How's it going to affect the cells? How's it going to affect the blood? So a hypertonic solution is doing what? Where is fluid moving? Okay, where's it going? Into the extracellular space. What's an example of a hypertonic solution?
0.4.
10% extra.
3%.
3% saline is going to be your kind of go-to. When you think about hypertonic, 3% saline, right? We're going to talk about the osmolarity of fluid real quick, just to kind of refresh that. But that is 3% saline, some other things that we'll talk about in a little bit. But that is going to shift the fluid out of the cell into the extracellular space. What kind of patient would you think would need a hypertonic solution? Cerebral edema, very good. So that's a common type of patient that would get 3% saline. What about isotonic? What do you notice about the cell? Normal, what does normal mean?
Like they have equal pressure inside and out.
So it's equal, right. So the movement is equal. We're not changing anything. We're not trying to do more pull. We're not trying to make it bigger or smaller with the cell. We are just trying to maintain a good balance. What kind of patient would be on an isotonic solution?
Someone getting the blood transfusion.
So I heard fluid deficit. I heard blood transfusion. So I'm going to ask you a question real quick, Katie. So I'm not trying to pick on you. So what is the only fluid that we can give with blood? Normal saline. Very good.
What kind of solution do you give to burn patients again?
So you can give a burn patient isotonic, you can give them lactated ringers, and it really depends on the stage of their burns. So you will get that definitely in advanced med surg, but typically they will have lactated ringers, because what's an LR? Electrolytes, those types of things, right? So they typically will be on lactated ringers, but you'll get them later. All right, hypotonic solutions. What do you notice about these cells? They're swollen. Why are they swollen?
A lot of fluid is in this.
So I have more water than what? Right, so thinking about your solutes, right? I have less sodium chloride. So this patient, the cell is swelling because the water is moving more into the cell. You see how y'all did that? We did it together. Y'all did good. All right. So when we're looking at our different types of IV fluids, you have your chart. It's tabled, I think it's like 10, yes, 10-5, table 10-5, and it talks about the different types of fluid. You need to make sure that you remember why we're given specific fluids and for what type of patient population. Because we're talking about fluid and electrolytes. Oh, go ahead, Emily, I didn't see your hand. Oh, when would you give a hypotonic solution?
Would you give them to an atrophy patient?
You can still give it to a patient who is dehydrated, so you can give it to expand the vascular space. If you have a patient who has issues with their sodium and they need water but not too much salt, you can also give that solution. We'll talk about that in a little bit too. So that also can be given for volume expansion for your patient. You just have to be careful, especially with like some of your patients with like CHF, that kind of thing. And your patients who are on isotonic fluids, if they have CHF, you gotta be careful with the sodium concentration. You're not gonna give those patients 3% saline, or you're gonna be really careful. We're gonna talk about that in a little bit too. All right, so just make sure you are aware of how your fluids work, the tonicity of them, and why we're giving them. Is this coming back a little bit from fundamentals? A little bit? Okay, all right. So you do have colloids and crystalloids. So crystalloids are those different salines that we talked about. Colloids are going to be those thicker things like albumin, dextran. Those things are going to look different than your normal saline. They're going to be used for different reasons. Because albumin is a very popular colloid, we do treat it a little bit differently in the hospital than when we administer regular crystalloid fluids. They have to be verified. You need to like put the lot number in, all these types of things, because your patient still can have an allergic reaction with a colloid. Typically your patients are not allergic to any kind of crystalloid solution, because typically those have more osmolarity in common with the blood. So depending on what your patient needs, they may be on a crystalloid or a colloid solution. So especially if we're trying to expand volume, a lot of times your patient may need a colloid solution, and we'll talk about that a little bit more too. All right, so when we're talking about fluid and electrolyte balance, specifically fluid balance, there's sensible and insensible losses of fluid and gains of fluid. Do y'all remember that word?
Mm-hmm.
So what's a sensible loss of fluid? Give me an example.
Like pee.
Urine output, okay, what else?
That would be
Would sweating be sensible or insensible?
insensible, 'cause you don't think about
So what's the difference?
it. You don't control it.
One can be measured and one cannot be measured, right? Sensible and insensible. So think about things like a fever. Can a patient who has a fever lose water? Can they lose fluid?
Yes.
Everybody's shaking their head yes. You know what I'm gonna ask you? Why? Okay, so they're sweating, they're perspiring. What else do people who sometimes have fevers do? Breathe heavy. So your lungs also, remember, oxygen, carbon dioxide, all these things are all ways that people can lose fluid. So just because it's not measurable doesn't mean that it doesn't account to what's going on with your patient. So sensible and insensible water loss. Your kidneys are probably I won't say the most important, but they're really, 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 really important when it comes to measuring our output for our patient, our sensible loss. So no, it sounds crazy, but what are you gonna measure from the kidneys? Like what are you gonna measure? Urine, I know, it sounded silly. I know. It sounded silly when I said it, but I already committed. So we're gonna measure urine output for those patients. What are we looking at with the skin as far as losses of fluid? We're gonna assess skin turgor, but we're looking at sweating. Are they severely diaphoretic, right? That's gonna contribute to their fluid levels. We talked about the lungs and their respiration. Are they breathing really fast? Do they have issues with their rate of breathing? And then through the GI tract, what might we be talking about as far as loss? Diarrhea, vomiting, okay? So all those things are ways that we lose fluid. Also, if your patient has an NG tube, right? They can lose they do lose gastric contents through there, and that can contribute to your client's fluid loss as well. So typically when we're talking about losses and gain, remember your body likes to maintain homeostasis. Typically what goes in your body needs to be very close to what comes out of your body, right? Like you want to have kind of this even keel. So that's why we do things like measure intake and output, assess daily weights. If you have a patient that has CHF exacerbation, they have their heart failure, it's just flared up, and we're gonna diurese this patient. We're gonna give them some Lasix or something like that, furosemide, something like that. Do you think you would want a positive fluid balance or a negative fluid balance?
Negative. I can do that.
So if you have a patient who has CHF, you're giving them furosemide. What's the purpose of you giving them furosemide?
To get rid of the fluid.
To diurese them. So do you want this to be a positive or a negative fluid balance? Negative. You want to pull off more fluid, right? Does that make sense to you?
No.
Tell me why it doesn't make sense.
What do you mean positive
Right.
and negative?
So positive means I'm gaining fluid. Negative means I'm losing fluid.
It's the way you word it.
Oh, well, that is the way that we word it in healthcare. So a positive fluid balance, a positive fluid balance is what we gain, a negative fluid balance is what is lost, right? So that, it does sound different, but that's why I need to make sure y'all are familiar with the language, right? The language is in your textbook, the language is what we talk about here. You have to be familiar with the language, because when you get tested on the exam, we're not gonna say, this is 200, this is 500, which one is better? I need you to get familiar with the language, okay? All right, so what kind of labs are we gonna use to assess fluid status?
Serum osmolarity.
Y'all have it on your slide, yes. All right, serum osmolarity, what is that?
The osmolarity of the
So what does that measure? So it's in the blood, solutes, right, specifically, so we're looking at sodium, those types of things. What is urine specific gravity? What is that? So the density of the urine, we're measuring the density of the urine. Remember, we looked at that last semester with renal. So we're looking to see how diluted or concentrated your patient's urine is. What is BUN? What is blood urea nitrogen?
urea.
Right, we're measuring the urea, the end product of that metabolism for your patient. Between that and creatinine, which one is a better indicator of your patient's renal status? Good, so your creatinine. So your BUN is gonna be more affected by things, your creatinine is gonna be, yes, hydration, that kind of thing, very good. Your creatinine is gonna be very specific to your kidney function. So if my creatinine is elevated, how is my renal function? I probably have a low renal function. I want to look at the GFR, but correct. Very good. All right, and hematocrit. What is the hematocrit?
That's red blood cell.
Is it the red blood cell? It's the percentage. Very good. So we're looking at the percentage of blood volume. So if I have a patient who has a high hematocrit, do you think this patient is hydrated or dehydrated? Dehydrated. Good. If you didn't understand that, I need you to write that down, because we're going to talk about that in a little while. But you got to understand why your patient's going to have these different lab values. If your patient is dehydrated, they're going to have an elevated hematocrit level. Okay? All right. So the maintenance of homeostasis. All of these things, when I look at them, we have talked about all of these things before, so I'm not gonna go over them too terribly. Take a minute, look at this chart, and see if you can figure out why this specific area of the body is responsible for maintaining homeostasis. If there's one that you have a question about, just raise your hand and we'll go over it, but just take a minute and ask yourself, do you know why this part of the body is maintaining homeostasis? Or how it's maintaining homeostasis? Bless you. Anybody have any questions they're willing to share? If not, I am available. Go ahead, Kelly. Baroreceptors, yes. What do y'all remember about baroreceptors? They respond to changes in blood volume, right? We're thinking about these are the regulators of the sympathetic and the parasympathetic nervous system. Very good. Good question. Very brave. Thank you. All right. Anything else from anybody? Go ahead.
The last one, didn't that have something to do with like right-sided heart failure?
Heart failure. So BNP, your natriuretic peptides. There's an ANP and a BNP, but we talked specifically about BNP last semester. So that does have to do with heart failure. Very good.
Yeah, help us out a little bit.
Oh, help you out a little bit. Okay, so what is a peptide? Y'all remember? Okay, so that's okay. So your natriuretic peptides are going to kind of counteract the renin-angiotensin-aldosterone system. So,
make you pee, basically.
huh?
Makes you pee.
It doesn't necessarily make you pee. It's an indicator of your heart function, of how much fluid is in the heart. Okay? So your natriuretic peptides are going to deal with fluid in the heart. So that's how they regulate homeostasis.
You said counteracts the nervous system?
Mm-hmm. Osmoreceptors are responsible for sensing sodium. Go ahead, Stephanie.
It's a hormone, right?
Yes, yes, it's a hormone.
It actually reacts in the heart.
Say that again?
It actually reacts in the heart.
It's directly related to the heart, yes. The BNP is yes. All right. So gerontological changes, things that are going to be different in your older clients. What clients do you guys think are going to have the most issues with fluid volume status besides old people? Babies, why? Y'all are right, but I need you to know why.
Most of their bodies made up.
Most of their body is composed of water. Very good. So your babies are going to have issues with fluid volume status because most of their body is composed of water. Your older adults are going to have different physiological changes as they age. So you want to look at things like decreased skin turgor, decreased kidney function, those types of things. Medication usage. We talk about polypharmacy kind of throughout healthcare, but that is a big thing for your older clients. So make sure that they know what type of meds they're on and why they're on those meds. And then like we said earlier, your patients who are older are going to have different responses to their fluid and electrolytes, and a lot of times their first change that you're going to see is a change in their level of consciousness. Yes. Was that what you were going to say, Shimori? Okay. All right. So this is something that I don't think that that was gone over last semester for fluid and electrolytes and foundations, but we're going to talk about it for med-surg. So there is a difference between your patient being on maintenance fluid and replacement fluid. What do you think replacement fluid is going to be used for?
Replacing lost fluid.
replacing volume, electrolyte, something like that. What about your maintenance fluid?
Just keep it, okay.
Correct. So who might be on maintenance fluid in the hospital? Somebody who is NPO, very good. So I would probably not give my patient who is NPO replacement fluid. They probably would just be on maintenance fluid. I'm just trying to maintain their hydration status. So if you've listened a little bit in clinical, you might have heard some of these words like KVO, intermittent, or INT, saline lock, HEP lock. These are all different things. They don't mean that your patient is on maintenance fluid. These are different terms that we'll talk about later on, but these are kind of things that nurses say about the rate or the type of injection that you're going to give your patient to maintain their IV. So we'll talk about that in a little bit. So a lot of your maintenance fluids will contain or may contain some kind of electrolytes in them. When we are administering electrolytes to our patients, are you going to give your electrolyte undiluted? No. We are not ever giving a patient straight calcium or straight potassium. That is a lethal injection. So they are always going to have it in something. Potassium chloride, sodium phosphate. We're not giving our patient straight sodium, right? That will kill your patient. Did you have a question, Chantel?
Would total parental nutrition be considered a replacement fluid or?
So it's going to be a maintenance fluid depends on your patient. It's not going to be a replacement like a bolus. It's going to be maintenance for your patient. Okay, that's a good question. All right. Oh, go ahead, Shabari.
So, would you give like a patient who is on the alcoholic replacement fluid?
So your patients who are alcoholics, they get replacement fluids, and theirs is usually full with electrolytes.
Okay.
So we call that a banana bag sometimes. We'll talk about that when we look at magnesium. Because it's yellow, that's why.
Okay.
Yeah. All right, so these are some examples of some clients who would be on replacement versus maintenance fluid. Your replacement fluids are going to be your larger bolus type fluids. These are going to be those large volumes. You're going to get a liter bolus of fluid. It's going to go in over 15 minutes, that kind of thing. Your maintenance fluids, they can be dosed per kilogram per weight for your patient, but these are also going to be your continuous fluids. So normal saline at 125, D5W at 50 mLs an hour. That's going to be this. If I'm giving my patient a bolus of fluid, you're always going to want to make sure that you are assessing your patient when they get the bolus. Because you want to listen to their lungs, their heart, and you want to check for any kind of edema, that kind of thing. And we'll talk about that in a little bit too. Any questions about why a patient would be on maintenance versus replacement fluid? Okay. All right. So we're going to take a 10-minute break. I will see y'all at 10.